present for us. And this is an article that Derek found interesting from his point of view of research. And then we're going to have two respondents from representing the other cores of the CFAR, the social, well, I shouldn't say that because Derek, I don't remember which core you're from, but anyway, well, I'm going to step back and let our presenters present themselves so that they can explain where they're coming from. So Jose, would you like to just start, please?
Absolutely. My name is Jose Lucar. I am an infectious disease physician by training. I am at George Washington Medical Faculty Associates as a clinician, and I'm faculty in the School of Medicine. I participate in a number of areas. I'm primarily a clinician. I see patients in the clinic, in the hospital, and I work closely with our partners in the School of Public Health with the DC cohort. That's sort of my main area in terms of HIV research, and I'm involved in other studies as well. So thank you for inviting me today.
Thank you. Alexander, Alex, would you like to introduce yourself?
Sure. My name is Alex Zestos. I'm an associate professor of chemistry in the Center for Neuroscience and Behavior at American University. Primarily, I'm looking at, in the basic sciences core, I'm looking at molecular mechanisms of HIV on neurocognition, specifically HIV-associated neurocognitive disorders, and looking at potential antiretroviral therapeutics and biomarkers for HIV and possibly correlations, comorbidities with substance abuse. Thank you.
Thank you. So then by elimination, Derek is representing the social and behavioral sciences core. As we said, then we have people looking at an article from different perspectives of their research interests. And what we hope we are going to do is foster collaboration, discussions. Other people who are on the journal club with us today are representing all sorts of different areas of research. So our sort of game plan is that Derek will have about 15 to 20 minutes, less if he wants, to present his article that he found interesting to him. And then we will have our respondents each give about a 5 to 10 minute perspective of where they found interest in this article. And then we will open it up to discussion. So Derek, would you like to introduce yourself and then do your presentation?
Sure, really excited to be here. Thanks everybody for joining. I'm Derek Dangerfield. I'm an associate professor in the Department of Prevention and Community Health at GW, where my research really focuses on domains of sexual health promotion, particularly for Black sexual minority men. This season, I'm wrapping up an intervention whereby we are increasing perceived HIV risk and PrEP initiation among Black gay men in Baltimore. And the article that we're talking about today is about motivations for illicit substance use among Black sexual minority men. So hopefully you all find it interesting and we can have some rigorous, robust discussion. Let's see if share screen works here. And I chose this, can everyone see the screen? See the slides? Okay, great. And I chose this this project not only because, not just because I led it, but we know that substance use is an important precursor to sexual risk-taking and HIV risk. We also know that most of the time in the literature, drug use is often generalized, but we know that there are differences in effects from opioids and stimulants. And we also don't pay a lot of attention to Black sexual minority men due to evidence that Black gay men use drugs at lower rates than white gay men. And so really information about what's going on in terms of drug use is really limited for Black gay men, despite the fact that marijuana and opioid use is actually increasing. So I was really interested in this work, especially this season, given what we know about what's happening with guys. And I'm really hoping that you guys find it interesting, like I said, and that potentially there's some points of collaboration so we can really take this work to the next level. So the premise of this, the story and the study is really to explore age-related differences in the profiles and motivations of particularly opioid and stimulant use among drug-using Black sexual minority men. And we did this project in Baltimore, Maryland in 2018. So it's a qualitative study in which we conducted 30 in-depth interviews guided by life course theoretical frameworks, whereby we asked guys all kinds of questions about their upbringing, childhood adversity, major events in their lives, the context under which they initiated substance use, and actually simply asking them, why did they begin drug use? We also conducted exploratory drug testing to identify the range of substances that folks were using. And then we did targeted drug testing to confirm the presence of those substances that were actually found. Also guided by life course theoretical approaches, we use these interesting timelines to kind of illustrate the relationship between major social events in society and the things that guys were reporting in the interviews to see if we could almost find patterns in the motivations and context under which folks were using the drugs that they were using, and if we could find patterns in behaviors across age cohorts. The sample of 30 folks included 40% of guys who were under the age of 35 and 60% were ages 35 and older. And those age groups were stratified by HIV epidemiology, since we know that folks under the age of 35 have the highest incidence of HIV and some of the worst outcomes of HIV care relative to the older folks. So that was the justification for the age stratification in that way. In terms of the differences by age group, we kind of see similar socioeconomics, but we do see, interestingly, that most of the younger folks were employed working full-time compared to the older folks, or employed at all relative to the older folks. Interestingly, also, we see that a large portion of the sample was already living with HIV. Over 80% of the guys who were under the age of 35 and over the age of 35 had self-reported living with HIV. Most of the folks in the sample identified as gay, homosexual, or even bisexual, and most were single and not married. Wanted to get into the nitty-gritty of the drug use profiles, which we really found some interesting stuff. For the younger folks, we saw a greater prevalence of marijuana use compared to the older folks. You see that 90% of the folks who were under the age of 35 reported and had confirmatory marijuana use, compared to the 50% of folks who were over the age of 35. Also, interestingly, we see that a greater proportion of the younger folks were using powder cocaine compared to the older folks. We also saw that a greater proportion of the younger folks were using prescription painkillers. We see 50% of those folks were using prescription painkillers compared to 20%. And also, we saw a greater prevalence of fentanyl, which we did confirm in the project among the younger folks. In terms of the themes that were found in the study, really interesting stuff in terms of the generational differences found in drug use initiation and drug use modalities. So specifically, older folks would suggest that drug use trends in the US and social activities. I'm not sure where my slides are advancing. Not sure why my slides are advancing, but specifically, older folks were suggesting that because drug use was social, they were using drugs in the late 70s, 80s, and were initiating drugs with friends. Also talking about specifically using injecting heroin, compared to the younger folks who would talk about initiating drugs with sexual partners, doing drugs to either enhance the sex or being vulnerable to substance use because of their desire to participate in the relationship with that partner at the time. And interestingly, in terms of drug use modalities among the young people, we found a pattern in folks reporting extragenital drug use, whereby they would report using specifically stimulants rectally to either enhance the high or enhance the pleasure during sex. In terms of developmental trajectories across age groups, we found that major life events along the course of their lives really impacted people's vulnerability to substance use across age group, especially those who reported events like childhood sexual abuse, neglect, and other experiences of violence and trauma. Another really interesting finding, which I think is one of the most powerful in terms of this notion of pain management, particularly the younger folks would talk about using opioids to cope with emotional pain. And I know that in the opioid epidemic right now in the drug research world, there's this real concept of we're really trying to interrogate how do we get at new measures of pain? How do we create those assessments in a better way to really start managing the opioid epidemic and the opioid crisis? But for folks to be explicitly describing emotional pain and using opioids as a coping strategy for emotional pain has really not been talked about and has been underaddressed, and was a really important and critical finding in this project that I thought is a point for discussion. Here's an example timeline that was in the paper, just really using the life course theoretical approach to illustrate some of these concepts that were discussed in the project, specifically thinking about the relationship between the AIDS epidemic and progression in treatment regimens, major drug epochs over the course of the history. So the heroin epidemic, crack epidemic in the 90s and 2000s, and even the resurgence of heroin and prescription painkillers. And then we broke up, or we took the average of major life events, HIV diagnoses, drug use initiation, coming out, those kind of developmental and behavioral characteristics, and map them onto the social trends and treatment trends in society, to really see if we saw some patterns in differences by age cohort. And this could definitely be replicated and scaled to see if there's really something there. But I just wanted to illustrate the utility of this approach for future research, not necessarily to confuse you guys and get all into the nitty-gritty of what's on the screen. But I want to open it up for discussion now. Do we have any thoughts from our respondents?
So why don't we have Alex go first, please?
Sure. Would you like me just to discuss or share slides? What is your preferred format?
Your preferred format is my preferred format. It's what you found interesting about this and what it
Okay.
might have you in your line of research.
Yeah, absolutely. So if you don't mind, I can share a few slides. I want to thank Dr. Dangerfield again for really an excellent presentation. I have a few slides that I would like to discuss here. And I'm not going to be able to comment on Dr. Dangerfield's work per se, but what I would like to say is, should I get it into, can you see the slides now? Give you the basic science perspective. So yeah, Dr. Dangerfield's paper was an excellent paper. What I would like to discuss now is the molecular mechanisms of these drugs of abuse, because we saw that there was differential usage between the youth and older population. And I want to understand why. I want to understand how the HIV brain is different than the non-HIV brain. Are there any comorbidities? And how are these different either psychostimulants or depressants acting on the brain? So my basic science perspective, one of the drugs that was discussed is amphetamine or methamphetamine. I really want to understand what effect it's having on the brain, and I want to understand what effect it's having on the HIV brain. So we've shown that methamphetamine has been abused by over 13 million people. ER, emergency room visits are definitely on the rise. How is amphetamine functioning? So really a psychostimulant is going to increase extracellular dopamine into the brain. The dopamine is going to give us this reward, reinforcement, this feeling of euphoria and craving, which will allow us to crave and seek other psychostimulants. The way that amphetamine acts is it's a molecular mimic of dopamine. As you can see here, it's very structural, similar to dopamine. It doesn't have those two hydroxyl groups. So it induces tachycardia, rapid heartbeat, hyperactivity, appetite and suppression, addiction and craving. It can treat attention deficit disorder, narcolepsy. However, it's used as Adderall, which is a drug that can treat attention deficit disorder. And the more bioavailable methamphetamine is more abused in the brain. So there's no treatments for drugs of abuse. We know that amphetamine functions on the brain. It serves as a substrate inhibitor for the dopamine transporter. It works specifically on the nucleus accumbens. It reverses dopamine transport, causes dopamine efflux at the norepinephrine transporter, the serotonin transporter as well. So our mechanism is that amphetamine can activate protein kinase C, phosphorylate the dopamine transporter, and then cause the efflux of dopamine into the extracellular space. Dopamine can then be sensed by the D2 autoreceptor, which can also control dopaminergic signaling and stop the synthesis of dopamine through L-tyrosine. So cocaine has a different mechanism. It's a different drug of abuse. As opposed to acting on the dopamine transporter, it serves as it blocks the dopamine transporter rather than serving as a substrate. So it actually increases extracellular dopamine in very high levels. So these are the psychostimulants that were discussed. The other two drugs of abuse that were discussed in the brain were more depressants or analgesics, right? We talked about endocannabinoids, and we also talked about opioids as well. Opioid abuse is a big pandemic causing overdose and death. As opposed to a psychostimulant, it can act as a depressant or analgesic. It can reduce extracellular dopamine in certain instances, and it can also increase extracellular dopamine in certain instances. They can act, opioids such as heroin, they can act, and fentanyl, which is discussed in the paper, they act on the opioid receptor, and the opioid receptor can induce dopaminergic signaling. As opposed to that, THC in cannabis or marijuana also has its cannabinoid 1 receptor as well, which can also increase and decrease extracellular dopamine respectively. So how does this relate to HIV? There have been many publications by Volsky and Gu looking at the eco-HIV model, where we can show that viral infection can establish latent viral reservoirs in T cells, so inducing HIV-associated neurocognitive deficits, or HAND. And we've also done other stats in animal testing as well, that selective monoaminergic and histaminergic dysregulation in long-term HIV-1 exposure as well. So animals that are either HIV or wild type have differential levels of these neurotransmitters in their brain, and it's the levels of these neurotransmitters that are affecting whether the animal will want to self-administer or abuse drugs of abuse. And we're trying to correlate this translationally to Dr. Dangerfield's work. Number one, what are the effects of these drugs of abuse in the brain? And what are the effects of HIV on the brain as well? And how is the comorbidity established between HIV exposure and also the abuse of psychostimulants? So what we've been discussing in this lab, now that we know the different molecular mechanisms of each drug of abuse, I want to go through some questions, and I don't have the answers to all of these. I would like to open it up to the floor. Whether we use or abuse drugs of abuse, there's two different categories. Number one, we're using opioids and fentanyl for pain, and I'm assuming that this is for HIV-induced neuropathy. And then there's the emotional trauma for the high, which we talked about several emotional scars during the paper, and people were abusing drugs of abuse to essentially forget about those traumatic experiences. So with different mechanisms and different applications, we have psychostimulants, and then we also have the depressants. There is a comorbidity between drug abuse and HIV. And the question that I have that we're studying in my laboratory right now is HIV neurocognition. Do neurocognitive deficits exacerbate drug use and sharing needles? The prevailing hypothesis is that individuals who are HIV positive, who are abusing drugs of abuse, specifically heroin, fentanyl, are sharing needles and spreading HIV. The question that we're asking in my laboratory right now is, does HIV itself cause one to be more likely to use and abuse drugs of abuse? So we're actually doing these experiments now. We're measuring the HIV strain of mice being tested on IVSA for heroin. We've shown that viral latency causes neurocognitive deficits, HIV-associated neurocognitive deficits, and there's a direct correlation between substance abuse and HIV status, where there's specific biomarkers in the brain that we're also studying, increasing extracellular levels of dopamine, serotonin, and whatnot. We're currently studying now whether we can give specific drugs that can act on these monoaminergic systems to actually reverse HIV-associated neurocognitive deficits. And we've seen that, the younger age of abusers, they, as Dr. Dangerfield just said, they're abusing marijuana, powder cocaine use, painkillers, fentanyl as well. And the main question that I have is, why is that? Is it because they are reducing dopamine to relieve pain, or is it because they are increasing dopamine to cause euphoria and to help people forget about traumatic experiences? And I think both are very important questions. Oh, and the question that I have is, what are effective treatments that we can have, whether therapy, whether a pharmacological drug treatment, that we can alleviate some of these conditions? So, that's the main question that I had for my paper, is that we've discussed several drugs of abuse. Each drug of abuse that these patients were abusing has different mechanisms. It has different effects in the brain, and it has different effects in an HIV versus a non-HIV infected brain as well. And how can we take this knowledge to have effective treatment and prevention for these patients?
I really
Test at all, and very interesting questions raised, but let's let our next respondent, Jose, chime in.
Yes.
Maybe there'll even be more questions by the time he finishes. Very
So many thoughts I have.
Do you want to go ahead and respond, and then I'll talk later, or?
You're responding to the article right now, please.
Okay.
Let's respond to the article.
Absolutely. Yeah, no, I also appreciate the opportunity to review your work, Dr. Dangerfield. And, I don't have slides, so I apologize for that. I will sort of comment on the things that were kind of highlights for me. And you kind of, before doing that, I'll just tell a little bit about sort of my experiences working in the clinic and seeing people both living with HIV or at risk for HIV. I'm originally from Peru, so I worked a few years in Lima as a sort of a general practitioner. Then I moved to the US, and I've been primarily in DC in sort of like the healthcare environment. But I did spend a few years in Jackson, Mississippi as well, where I also kind of worked in different settings. I work in a clinical open arms. Some of you may have heard of it. It's sort of part of the My Brother's Keepers group with Leandro Mina, and at the University of Mississippi as well, which had a sort of a Ryan White type of practice. Now I'm here at GW, which has somewhat different sort of structure of the clinic. So the reason I mentioned this is because as I go through your work, I always think about how do we adapt these sort of different clinical environments to serve these individuals who have such a and I'll say first, it's striking the level of adverse childhood events that these people have, sort of these AIDS events, and sort of the association with drug use, which is just remarkable. And I think of how the healthcare, the sort of the average healthcare environment is not really built up to serve these individuals. And one of the things I think of is the amount of time that is allowed to have these type of conversations. There's if you've been in the healthcare environment world, the amount of for the average clinicians is sort of the waiting times and the short visits, those 10-15 minute slots. And how do you get everything during those meetings, make sure that all preventative care is done, vaccinations, screening, talking about adherence. How do we get into, honest dialogues with patients by listening to them? Like what are their life experiences? That's really, I often think about how do we adapt the clinical environment to better serve these folks. Kind of one of the key questions I have is, over the past several years, I'm sure you're all aware, is the trauma-informed care perspective, which I think kind of follows the theme of your article and your work, is how much first is how widespread it is utilized. I know that it's been a key effort by SAMHSA to sort of get it implemented at the settings where there are Ryan White funds. If you go outside of the Ryan White world, even there's a couple articles that I was reading last night, sort of as I was preparing to discuss about this. Even within the Ryan White world, the implementation has been probably quite slow. And there are a couple of papers from the South, researchers from Emory and I think from Texas, looking at even with the funds and with the setting. I mean, the uptake of these has been relatively small. So how do we get to a better place for that? And then following up the sort of implementation of trauma-informed care is that does it work? And we know that in many ways it does, but for this subset of sort of sexual minority people who already have so many risk for adverse health outcomes and who are already particularly vulnerable, does that really impact adherence or things like virologic suppression and sort of treatment for drug use disorders and things like that? So the two main things that I took from your work is how do we adapt sort of different healthcare environments to serve individuals, and as we adapt those, are those changes effective into better serving people? I mean, we may assume that they may do, but I think it would be important to measure that, both at the sort of in the type of work that you did, which is sort of the missing the word here, qualitative, thank you, qualitative approach and sort of how to find sort of those quantitative or findings in terms of things like virologic suppression and adherence and satisfaction with care, etc. A couple of final points that I wanted to bring up to the discussion is, as you all know, we have, of course, a number of clinical trials in terms of new therapeutics for HIV treatment, and there are more long-acting medications that are coming down the pipeline. as I'm sure several of you know, there has been, of course, interest in studies looking at the role of long-term injectables for people who have drug use disorders. How do we get to that point? And there was, of course, some interesting data published in the past year about that. Are sort of and as I'm sure you know, the implementation of some of these newer therapies has been difficult. But could that be implemented to as part of a comprehensive approach and allow more time spent to go over drug use disorders and things like that? And sort of how do we implement sort of newer therapeutics into caring for these folks and allow more time to be spent for other issues that are probably as important as their being undetectable and so on. So like I said, I found your work very interesting. I kind of thought about it from different hats that sometimes we wear. And primarily I thought about how do we adapt our clinical setting to better serve these folks. That's kind of my biggest take out of it.
Thank you, Jose. That's exactly what we hope to do with this journal club, is to have people think outside of their hats. But now, as we said before, what I'd like to do is open it up to see if there are any comments or questions from the other people who are attending the journal club. I know, Alexander, you had questions, but we'll see whether or not we have anything from the audience first. I have one question. I will start by asking, these older men, Derek, that you said started because of a societal influence, do they maintain that through their thing? I mean, when you talk about the younger people who are essentially using for the emotional pain, the older men and did not exhibit that kind of thing. It was more still a social use of drugs.
That's a good question. I think that ties into my comment about Dr. Zesto's work, which is really, really exciting. While it's true that across the age groups, folks describe, childhood adversity, when we talked about how they initiated, that's where we saw the differences. And I think what's happening is that, the substances, of course, are reinforcing, as we're talking about. And so it's not always, I'm at a party now there's abuse, now there's misuse, now there's possibly addiction. So we didn't necessarily measure the substance use in that way to actually clinically define their use as abuse in that way. But the motivation for how they got started was the social stuff.
Okay. Anybody have any questions for our three presenters or comments? Alan, yes.
Thank you, Sylvia, and thank you all for your brilliant presentations. I just wanted to call attention, as some of you may know, we have a wonderful substance use, drug user health scientific interest group, and it's very well attended by members of the community who are extremely engaged in providing services to persons who use drugs in the district, and really with a focus on drug user health. We also have a number of members of the health department who are responsible for programmatic support. There are a couple of people from NIDA who sit in, and it's Monica Ruiz and Irene Coe who are the investigator co-leads, and George Carr, our CPC chair, and Tony Young, who are the community leads. And it's really an incredible meeting every month. And I think, sometimes we have so many community people who are interested. Sometimes they outnumber actually the investigators. And I just think, if with your permission, Derek, I'd love to, ask Monica, who I guess you're in the same department, PCH, if they'd be willing to invite you to, present some of your findings and interact with the community groups who in the district are responsible for providing services. I think that would be a tremendous learning experience for them. And also, you could meet in one meeting, you could meet everyone, I think, or as many people as we've been able, like about 20 people who are working directly in the community. So.
No, that would be great. That would be great.
And for me, it's fascinating. Sometimes it's been over the course of the CFAR in the last 10, 15 years, there haven't been that many of our investigators who've been working on drug user health, and it's of great frustration sometimes to the investigators and community members who work in this field, and to NIDA as well. And so to me, I just, hearing such expertise in the laboratory and from the clinical perspective, and obviously from Dr. Dangerfield's, enormous social and behavioral contributions, I think this is really heartening to me, because for those of us who've been working in this field for many decades, it's great to see DC. We now have expertise. I think the three of you weren't involved in the CFOR, let's say even 5 or 7 years ago. So knowing that you're all here now, it really gives us a lot more things that we can accomplish. So just express my gratitude to all of you for your important contributions, and today and in this in this community that doesn't always get the attention from scientists that it should. And so thank you all for your important work.
I also think we take just really quickly, I also think we take the drugs for granted, right? We say, we lump all the drugs together and just label people addicts or abusers, and we don't really get into the nitty-gritty. I'm glad that I got a chance to show you all the timeline to really start thinking about how everything is everything, right? Like how where people are in society, where people are along the course of their lives, all those things kind of come together, and it manifests clinically as the drugs are reinforcing and changing brain structure, and in chemistry, and HIV diagnosis also exacerbates that. So it's really, really exciting to think about ways we can expand this work to really, really target this important experience that folks are having that's exacerbating their poor health outcomes. So I just wanted to make that point very briefly.
It's very important. Very important. Yes, yes. Jose, were you going to say something? Yes.
Yeah, there were a couple of things that I had written down that I thought maybe worth mentioning. One is every aspect of healthcare has been looked at through the lens of COVID-19. And I wonder, you did this study. I was just looking at when were the interviews conducted, December of 2018 to March 2019. So obviously pre-pandemic. Is there, I know that we're looking at a lot of different things through what happened after COVID. Where they be sort of, how did that impact sort of particularly those youth, sexual minorities, to even, would there be a much steeper increase in terms of, new drug use because of isolation and other reasons. So I think that could be an interesting area of research to sort of recreate what you did maybe in a different era, or sort of measure whether there's been an increase in the incidence of new drug use there, focusing on this population that you studied. And then the other thing is the unfortunate, how will the increasingly hostile social climate, for particular in certain parts of the country, how will that impact drug use? And I know that this is it's different depending on where you are, but like I said, there are certain areas where all the new laws are created, and which may sort of disenfranchise people to even sort of present to care. So those are two things that I
for sure,
in the type of effort you're doing, and how would those things impact the trends that you measure?
That's a good point.
Very good. I wonder, is there the same data available for women on drug use? I mean, there are reasons for starting. Does anyone know? Are women the forgotten?
I'm not sure if we looked at it in this way.
Well, it's interesting to me to think about the fact that, of course, with the epidemic through the years, we realize how many women are affected, women and everything like that. Reasons for why they're drug users. I'm sure there are female drug users out there. That's also something that I was going to say. But Alex, you had questions that you were going to ask. I don't know whether you still want to ask them.
Sure, I do.
Sorry.
Again, I want to.
Sorry for interrupting. Sorry for interrupting. I just see a hand up. So I think, Ted, you wanted to respond to that last comment before we change the topic?
Hi, no, it's a different question that I've got, so I'm happy
Oh.
to.
Oh, okay. Sorry, I didn't see your hand up. I'm sorry.
No worries.
You want to ask a question, Ted, first before?
Either
We
way
let-
is fine.
Okay. Well, thank you, Dr. Dangerfield, for the presentation. It's really interesting. I'm a doctoral student at Hopkins at the Bloomberg School. So I'm a bit ticked off that you left. But Dr. Dangerfield, if you could tell us just a little bit more about the methods that you used. It's a sort of a student question, I know. How did you recruit them? How did you gather and analyze the data? And reflect on what might you have missed which is always a question for qualitative research, right? I mean, do we have the 30 people who matter the most, who are able to tell us the most about the topic? Or do we have people who, are we going down the wrong track? And did you do anything to make sure that this group of people who are particularly highly vulnerable, as Dr. Lucar said, did not come to more harm as in the process of participating in the research? Thank you.
Mhm. No, those are all great points. And of note, every project that I do, particularly with Black gay men, I always leave everyone with some type of resource, a resource list and or a warm handoff to mental health and substance use resources of their choice. So that is definitely something we always do in every project. One of the things that I think, because this project while it was funded by the Hopkins CFAR, this project wasn't necessarily an HIV project. It was more about drugs. And so I think in terms of what was missed, which we're talking about this afternoon, is really thinking about the role that HIV plays in people's motivations, decision-making, and behaviors, whether or not that impacts adherence. Those are kinds of things that I think we could have explored a little bit more in depth that we didn't, because I didn't want, for this particular project, we really wanted to focus on, everybody is always looking at Black gay men's sexual health and HIV lives through an HIV lens, and we wanted to kind of approach it from a different way, but we can definitely add that back in because it is salient for substance users, right? The other question that you asked was about, are we getting the right people? Are we, and those kinds of things. So we intentionally recruited a sample of men who were substance involved. So we don't know anything about people who may have had histories of substance use and now they're sober, which is also a really interesting kind of life course, journey that's really kind of understudy, like what happens after, once you maybe had a 5-year season and now you are doing something different and you may be still living with HIV or not. I don't know. So yeah, I think you bring up good questions, good points, and no study is perfect, but I think we have some good points that have been brought up for future research that I'm really excited to be thinking about.
Any other, Alex, you have your hand.
Sure. Yeah, I just wanted to follow up with Dr. Dangerfield's presentation again. Again, thank you so much for giving such a great talk. My specific question is, have you seen any participants in the study that are primarily abusing only one drug of abuse at a time, such as only opioids, only fentanyl, only psychostimulants? Because I think that you alluded to in your article that many with progressed HIV are taking opioids and fentanyl for treatment of pain. And then the younger patients are abusing psychostimulants to essentially forget about traumatic experiences. And if we can understand which drugs, which subpopulations are specifically taking, that will open up many avenues for treatment and prevention too.
Yeah. No, that was a good, and you kind of alluded to that point earlier, and that was a good point. But we did see, and we didn't quantitatively study it like that, but what we did find the pattern of, especially among the younger folks, is that almost all of them were using marijuana plus something else. So really interesting to think about this relationship between marijuana and stimulant and marijuana and opioid use, particularly among our young folks. But we do know that there is a high prevalence of polysubstance use. What I was really interested in is the distribution of those patterns. Like, why are you using marijuana and cocaine if they do two different things to you? You know that. So, but you bring up a really, really interesting point about polysubstance use that we know is actually happening.
Great, thank you.
Derek, do you know of other research that's been done with the same subject as far as drug use with another possible long-term illness or fatal illness that someone's having? Any comparisons of what people are finding with drug use?
I haven't seen it in that way, if I understand your question correctly, but what we have seen is folks, there are some studies with folks following substance users to identify changes in substance use over time using some latent variable modeling. So some people, like I mentioned, some people maybe start off, for example, using marijuana and then they progress to something else, or they start off using marijuana and cocaine and then they change substance use over time. I haven't studied the relationship between substance use profiles and effects on other chronic conditions, but I have seen projects where they are following substance use patterns over time, and the effects of the substances on, for example, sexual risk-taking, drug use modalities, in that way, if that makes sense. But I'm not saying it's not out there.
Yeah, I was asking because Alex showed, the metabolism.
Yes.
And then the fact of a virus in there. So I guess I should have said a viral infection or some
Yes.
infections that might have a pathophysiological effect on the transmission, whatever, how drugs are transmitted, the neurotransmitters. It seems to me that if this is coming up, your findings related to HIV, is hepatitis the same or something else?
Right.
Yeah.
No, that's a good point. And
interesting.
HIV, the viruses are so smart. So that relationship definitely needs to be explored further.
You don't have to tell me how smart they are. I know. Any other questions? Or Alex, what were you going? I don't know whether you've had a chance to ask your questions. Have you?
Yeah, I asked all my questions. Thank you.
Is that all your questions? Okay. Well, any other questions or? Oh, Brandy has a hand up. I think that's a hand. Is that a hand? No?
I don't think it's a hand.
Oh, okay. Oh, Diana.
I actually didn't have my hand up, but I'll take the moment to say.
Well, it's in your, it's my hand. I'm sorry. It was my hand.
I'll say thank you to Derek and to the discussants. I think it's a really interesting conversation to see the different disciplines, approach this and offer complementary perspectives. And, one of the things I'm just struck by is, and it's kind of a philosophical question, is how in public health are we addressing emotional pain? Emotional pain is often to the individual clinical domain, and yet it is underlying so much of what's going on in public health today in terms of disparities. And so I just think it's a big challenge for us, not only in the HIV field, but more broadly. So it's given me a lot of food for thought.
I agree.
That's
The
good.
other thing I'll say about really quickly to the earlier point about the clinical engagement is that, you know, clinical programs, clinical training in substance use is very, very minimal. Not a lot of clinicians understand the effects of drug use, don't know the epidemiology of drug use profile, you know, drug use profiles and effects. And there is not a lot of guidance on screening for substance use. And so really thinking about, you know, how do we have this, you know, clinical intervention where there is limited time, but simply screening for substance use beyond, oh, are you using meth as an indicator for HIV risk, could, you know, also build rapport, you know, be a mechanism by which we build rapport to understand how people are living their lives. Is something that I think about too.
Well, it's getting to the time where we have to log off, but I want to thank Derek for presenting a very interesting study and the respondents for giving their perspectives, and thank you all, really. We will be doing this again next quarter, which is April, May, June sometime. So if anyone would like to lead a group on an article they find interesting from their point of view, we will find respondents for that. But again, thank you, Derek, Alex, and Jose. It's been, oh, Alan, did you want to say something?
Yeah, just as follow-up, Sylvia, I definitely think it would be incredibly exciting to link these brilliant scientists with the really robust community experts that we have that participate in the drug user health sig. And with your permission, I'll be following up on that. I think that would be a wonderful conversation for everyone. So thank you.
Wonderful. And if anyone has any, you know, thing they want to discuss, please contact. We can get you to the right, well, the membership directory of the CFAR lists everyone's email. And everyone have a wonderful day, and thank you again.
Thanks,
Take care.
everybody, so
Thank you.
much.
Take care.
Bye.
Thank you.
Thank
Bye-bye.
you. Thanks.